Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausmann. Show notes for this episode can be found at acronair.org. This is our third and final episode of the 2021 ACR Vasculitis Foundation's guidelines for the management of systemic vasculitis. In the first episode of this series, we discussed ANCA-associated vasculitis. The second episode addressed large vessel vasculitides, including giant cell arteritis and Takayasu arteritis. In this final episode, we discuss the recommendations regarding Polyarteritis Nodosa. I'm joined again by Dr. Sharon Chung, the lead investigator of this project. She will walk us through the diagnosis of PAN, including the role of vascular imaging and biopsy, the benefits of CTA versus MRA, long-term outcomes of PAN, the need for physical therapy, the similarities and differences of PAN and DATA2, and whether you should test your patients for DATA2 mutations. We also step back and discuss the challenges of developing these guidelines, where our knowledge gaps lie, and how the committee will update the guidelines in the future. And now, on to our show. Sharon, thank you so much for joining us again on this third episode about the ACR Vasculitis Foundation guidelines.
Thanks, John, for having me.
So one of the questions I always think about when presented with guidelines is, how do you balance the need to provide individualized care to the patient that you have in front of you with guidelines or these algorithms that sort of tell you how you should treat patients? How do you manage those two?
I think the important thing is to remember that these are guidelines and recommendations. These are not absolute mandates. And your patient's manifestations and your patient's treatment history trump, in some respects, everything we say about the guidelines. So, for example, we may recommend rituximab over cyclophosphamide. But if your patient is a patient who's never responded to rituximab in the past, then that's a no-brainer. You should go for cyclophosphamide. Mm-hmm. If your patient is someone who hasn't tolerated a particular medication, then don't do it. Go with the alternative. So these are guidelines and roadmaps. These are not mandates for therapy. And I think the other important thing is that these guidelines provide you options. They provide you options to consider for care. We're not saying that you must do X or Y or Z. We're saying these are the options that you should consider in this situation.
Fantastic. And with that, let's dive into Polyarteritis Nodosa, certainly another rare disease that,
increasingly
we see a handful
rare.
of.
Yeah.
That's right. Right. So it used to be associated with hepatitis B. Now that most people are, at least in the United States and through some of the world, are vaccinated, certainly the incidence seems to be decreasing. We still think about it mostly in the inpatient setting where somebody's coming in with fevers and weight loss, and they may have some abdominal complaints or abnormal imaging. We always think about, or at least I do, Polyarteritis Nodosa. So how do we think about diagnosing a patient such as this? How do we diagnose PAN?
So I think, diagnosis of PAN, I usually think of two things. One is vascular imaging, and usually abdominal vascular imaging. And the second is biopsy. So when it comes to suspecting patients of having PAN, especially those patients who have abdominal symptoms, we conditionally recommend getting abdominal vascular imaging. And that is usually, that can be either CTA, it's usually a CTA, or catheter based angiography.
Mm-hmm.
And there are different practice patterns across the country about whether you start off with CT angiography or you jump directly to catheter-based angiography. There is a recognition that at this point, so in 2021, catheter-based angiography still provides better resolution than CT angiography, especially when vessels dive into the viscera. So if you're interested in trying to see whether or not they're microaneurysms or other smaller manifestations of disease, catheter-based angiography may be the way to go. However, if you're doing primarily more of a screening kind of testing, or you're not quite sure about the diagnosis of PAN or your pretest probability, it's reasonable to start off with something like CT angiography. And if your CT angiography is negative, but you still have a strong suspicion of disease, then you may consider going further with catheter-based angiography.
Sharon, one thing you didn't mention was MRA. Is there a role for MRA in the diagnosis of PAN?
I think what we need to consider is just vessel size resolution.
Mm-hmm.
So MRA, I think of as I'm far more comfortable with large vessel imaging. But when you think about medium-sized vessels and smaller than medium-sized vessels, especially in the mesentery, I think the resolution for MRA at this point is not as good as CTA. So if, considering between the two, I would actually favor CT angiography for PAN because it has a better resolution.
Fantastic. And the other thing that you mentioned about diagnosis, in addition to imaging, was biopsy.
Yes.
What do you biopsy?
You biopsy something that is symptomatic. So we don't recommend blind biopsies. They were done in the past, but I think most of us don't do that anymore. You biopsy something that's symptomatic. So for most patients, that's likely skin or nerve.
Yeah.
So for skin, we would actually recommend, what's called a deep skin biopsy, something that's going to get you to a medium-sized vessel. I think the risk is with the superficial punch biopsies, you just don't get deep enough to get a medium vessel. So with skin biopsies, you want to go deeper. This may be a surgical biopsy or an elliptical biopsy. And for patients with neurologic manifestations, we would recommend biopsy of nerve and muscle over nerve alone. It's because we often can pick up findings of vasculitis in the muscle that's not necessarily seen in the nerve.
Fascinating. So a combination of imaging and hopefully some type of biopsy to make the diagnosis of PAN. And then again, initial treatment. Do we think about the treatment of PAN similar to that of an ANCA-associated vasculitis with sort of induction of remission in the same way?
So I think, unfortunately, PAN suffers from its rarity in that we actually don't have a randomized controlled trial of PAN therapy. So how we treat PAN is based on our practices of ANCA-associated vasculitis, where we think about remission induction and we think about remission maintenance. But this is primarily a carryover from the ANCA-associated vasculitides. This is not a treatment algorithm that has been specifically studied for PAN. And I think also as an indication of its rarity and the lack of clinical trials, in our guidelines, we still recommend the use of cyclophosphamide for severe PAN. And it's because we don't have the experience in PAN with other agents such as rituximab, where we would have enough confidence to say, yes, you can treat PAN with something besides cyclophosphamide.
Should we also think about induction of remission with cyclophosphamide and glucocorticoids, and then remission maintenance? Do we think about azathioprine and methotrexate? Are those the main agents?
And we do. I would say so remission induction of severe disease with cyclophosphamide. Nobody should be kept on cyclophosphamide forever and ever and ever. We definitely should transition patients to remission maintenance therapies. Those therapies are typically methotrexate and azathioprine because that's what we have the most experience with. But I'll be honest, we don't have great data for that. It's just, our clinical practice.
Yeah.
I will say something a little bit different, though, for PAN compared to ANCA, the ANCA-associated vasculitides, in that the guidelines do recommend that patients are stopped off of remission maintenance therapy
There's
after
an
a period of time.
endpoint.
There is an endpoint, and we say 18 months, or actually, we say that patients should be stopped on therapy and should not be continued indefinitely. Most of the time, that's around 18 months, and that's because there's a recognition for patients with PAN that some patients have a monophasic disease. And so once something happens, it may not happen again. So that's actually unusual compared to our recommendations for the ANCA-associated vasculitides.
Yeah, one of the things that surprised me about the guidelines is in the initial sort of introduction about PAN, it quoted a mortality of about 40% at 5 years. And I was really struck by how high that was. Do you think those figures are still accurate?
I think therapies for the vasculitides have changed dramatically in the past 10, 20 years. We're using less cyclophosphamide, we're using less glucocorticoids. And so I would say that those mortality studies may not be as applicable given our current therapies. Now, my hope is that the mortality would be less than that. Maybe this is another topic that we should put a plug in and say, we need more information. Somebody needs to do research on this. I would hope that the mortality is less than that. In my own clinical practice, the mortality is less than that.
That's good.
And I suspect that just reflects past treatment strategies.
Yeah. And, I think another thing that I think struck me about reading the PAN guidelines as compared to the others was in the others, you were very adamant about trying to reduce glucocorticoid exposure. And I didn't remember reading comments about trying to reduce glucocorticoid exposure or limiting the amount of glucocorticoids that patients with PAN receive. Is that just because we don't have that data?
We don't have that data. So, for example, in the ANCA-associated vasculitides, we had a dedicated trial looking at reduced dose glucocorticoid regimens. For giant cell arteritis, we had a dedicated trial where, we used one particular agent to see if we could taper glucocorticoids more quickly. I would say that this premise of reducing glucocorticoid exposure also applies to PAN, but we don't have studies where we can say, do this, because outcomes are the same. But I think in general, we should be reducing glucocorticoids.
Yeah,
for
totally
our patients.
agree. And in addition to medicines, is there anything that rheumatologists and patients should be doing to try to, optimize the treatment for people with PAN, such as physical therapy or other modalities?
So PAN is we mentioned this specifically for PAN, but I think I'll just say that this is likely applicable to patients with any type of vasculitis with nerve and muscle involvement. One of the things I often tell my patients is that I'm working on controlling their inflammation with the medicines that we use, but I cannot rebuild their strength with the medicines that I use. That they are the primary instigators of rebuilding muscle strength. And what I mean by that is that, for patients with PAN who have nerve and muscle involvement, if they've had neurologic compromise or muscular compromise, modalities such as physical therapy are key for them to regain their, neurologic function and to regain their strength. Immunosuppressive therapies are not going to regain their strength for them, but their own physical activity will do so.
Fantastic. And then the other thing I noted that differed between the PAN guidelines and the others was the potential role of genetics. I think you mentioned data too, sort of thinking about testing or optimizing your treatment for patients with DATA2 mutations. How should we think about testing?
I think So one of the reasons we put data 2 in the guidelines was to increase awareness about data 2, because treatment for data 2 is in some respects diametrically opposed to treatment for
Yeah.
PAN. So even though these two diseases may have clinical manifestations that overlap, there's significant experience now showing that medications such as cyclophosphamide, and
Hmm.
instead, we really should be considering other therapies such as TNF inhibitors.
Yeah.
So I think it's important for clinicians to recognize that there is another entity out there that looks like PAN that shouldn't be treated with cyclophosphamide.
Yeah. So, Sharon, should we be testing all patients with PAN for mutations in data2 or measuring 88.2 levels?
So that is actually one of the aspects of the guidelines that people were fairly unhappy about that we did not address. So I think
Oh,
this is a
interesting.
very relevant question. One of the reasons we did not address it in the guidelines was that at the time we had no published data about the prevalence of data2
Hmm.
mutations in PAN. Since we had our voting panel meeting, there was a study published using the Vasculitis Clinical Research Consortium's cohort of PAN patients. It was just under 100 patients, and about 6% of those patients
Hmm.
had PAN, had data2 mutations, some of which were functional and some of which were not.
Hmm.
So I think, the question of whether or not one should test for data2 mutations, I think is still up in the air. And I think in my mind, it is dependent on your patient's presentation. So if you have a 23-year-old patient who's coming in with these large skin lesions and recurrent ischemic strokes, hands down, that patient should be tested for data2. If you have a 76-year-old who is presenting with, mononeuritis multiplex and ulcerative skin lesions, I think my pretest probability in that situation is not high. So I think it is very dependent upon your patient. If you have a question, if you feel that the patient may have data2, or there is a suspicion that the patient should have data2, go ahead and get the patient tested, because if the patient does have data2, as I was mentioning, your treatment strategy is going to be dramatically different.
Yeah, I think from those studies, the efficacy of TNF inhibitors to prevent strokes was like almost 100%.
Almost 100%. So there some would say, and this needs to be studied further, cost effectiveness analyses and things along those lines, but there are those who endorse data2 testing for all patients with PAN because the efficacy of TNF inhibitors at preventing ischemic strokes is so high. I'm a genetics investigator, and I'm not quite in that camp yet. I still, would tailor testing based on the patient's presentations. But, just to let people know that there are some who favor data2 testing on a broad scale.
And is there a role of genetics in some of the other vasculitides that we had discussed previously?
I wish there was. As I said, I'm a genomics investigator. It would be great to have genetic testing for, our other systemic vasculitides, but we don't have that yet. The genetic polymorphisms that have been associated with disease are not specific enough. Their, odds ratio for the risk of developing disease is not high enough for us to do it broadly across the populations.
Anything else that the team found surprising, or some questions in specific about PAN that the team wasn't able to answer?
I think, as we implied this earlier, PAN is a rare disease. It's essentially the only one of our systemic vasculitides that hasn't been studied with a randomized controlled trial, in part because it's so rare. And thus, the recommendations for PAN were driven more by expert opinion than they were in the other diseases. So, if there are motivated individuals out there wanting to do research on PAN, by all means, go for it. We need your help.
Fantastic. And one last questions about guidelines. We started this episode discussing about sort of the need to balance individualized therapy for a patient versus these sort of guidelines that some people view as sort of algorithms. One of the other concerns about having a set of guidelines is how to incorporate new data into the guidelines, right? So, next week, a study may come out, disputing or some of the findings of the guidelines or adding new treatments that may be more effective. So how is the ACR and the Vasculitis Foundation going to update the guidelines and going forward?
One of the reasons why the guidelines took as long as they did was that the literature review search was conducted with the intention of updating the guidelines in the future. So there were specific techniques implemented, softwares used, strategies used, such that with the expectation that in a certain number of years, we will revisit these guidelines, incorporate new data, and reassess and revote on these recommendations. So we consider these, in some respects, living documents.
That is fantastic.
I hope I'm not, overstepping my bounds, but the expectation is that there will be additional vasculitis guidelines in the future.
That's fantastic. So I'm looking forward to interviewing you yet again in another 5 or 6 years once your team. So if you want the guidelines to come out by 2026, then you better start working on them today.
Well, one would hope that, since we have this, we've gone through our steep learning curve, so we can do this more quickly in the future.
Fantastic. Well, Sharon, this has been really wonderful to have you here and discuss the Arthritis Foundation, the American College of Rheumatology and Vasculitis Foundation guidelines for vasculitis. And thank you for being here and sharing your expertise and understanding about these guidelines. And hopefully I look forward to speaking to you again when these guidelines are updated.
Thanks, John. This has been a lot of fun.
I hope you enjoyed our final discussions about the 2021 ACR Vasculitis Foundation recommendations for the management of polyarteritis nodosa. If you haven't already, please check out the first episode of this series where we address the recommendations for ANCA-associated vasculitis, as well as the second episode of the series where we discuss giant cell arteritis and Takayasu arteritis. If you're a vasculitis fan, don't worry. I hear there are guidelines in progress for the management of Kawasaki disease, and we'll discuss those as soon as they become publicly available. That's it for our show today. Don't forget to rate and subscribe to our show on Apple Podcasts, Spotify, or on your favorite podcasting app. You can also find all of these episodes and notes for our show on acronair.org. Until next time, please get yourselves vaccinated, get your patients vaccinated, and as always, stay healthy.